I'm Dr. John Cruz. Today I'm going to be talking about restless leg syndrome and ADHD. So restless leg syndrome is a fairly common disorder. It affects about 10% of the general population. It's characterized by a sensation of needing to move your legs, and that feeling of needing to move your legs is alleviated by actually moving your legs. There is considerable overlap with ADHD, so both people who have ADHD are much more likely than the general population to have restless leg syndrome, and people who have restless leg syndrome are more likely than the general population to have ADHD. And some of this overlap is there probably because of mistaken identity or misdiagnoses, but there is good evidence that there is shared basic pathology for the two conditions, so it's not surprising they are more commonly found together than you would expect by random chance. And what seems to tie them together is that there are evidence that a significant number of people in both conditions have low iron in certain levels in certain parts of the brain and certain abnormalities of the dopamine system. In restless leg syndrome, dopamine agonists, so agents that work to activate or bind to dopamine receptors and activate them, are helpful. Most of the formal studies are fairly short-term for showing how long they help. And there is amazingly little data, given this overlap, looking at any of these agents that are used for treating restless leg syndrome to see how effective they might be for ADHD. And there's also very little hard data on how well or how often the stimulants used for ADHD are helpful in restless leg syndrome. Restless leg syndrome is considered, in the US anyway, in most Western countries, the fourth leading cause of insomnia. That may be a little misleading in that sleep apnea, obstructive sleep apnea, where air passageway is blocked, usually constitutes at least 80 to 90% of what sleep study clinics see or are indicated for polysomnography sleep tests. And I do have other talks on this channel on sleep apnea and ADHD. And again, it's characterized by feeling that you just absolutely need to move your legs. And this can be one leg or both legs. It's usually both, but it does not have to be symmetrical. It can vary over time. It can vary each episode. Other parts of the body are less likely to be affected, but it can affect torso, upper limbs. It can even affect facial muscles. And the second feature of it is that when those muscles are at rest, particularly at certain times of the day, it just feels unpleasant, uncomfortable. So separate from the drive to move, there's particularly at rest, at relaxation, it feels really uncomfortable. And the third feature is that when you actually move, if you have this condition, move the muscle, it alleviates. It's helpful for reducing that sensation. There is a prominent circadian rhythm or daily rhythm to this restless leg phenomena. So it tends to be worse in the evening at nighttime, and we will get to at least leading theories as to why that's the case. And a feature of the formal definition is that the restless leg movement has to be not attributable to another mental health or physical health condition. Now, there are certainly other conditions predispose people to restless leg syndrome, and one of them actually is pregnancy. So up to a third of women during pregnancy will have some degree of restless leg syndrome or symptoms of restless leg syndrome. And that's thought to be connected to anemia. So anemia, which is low levels of red blood cells particularly, is clearly a risk factor for developing or worsening of restless leg syndrome. Obstructive sleep apnea is also a risk factor for restless leg syndrome. So being short of breath, having apneic episodes where you stop breathing leads to deoxygenation, and that seems to be the trigger. And it's tends to be a chronic condition. So it's not just the damage or risk from one episode, it's the ongoing oxygen deprivation that seems to be toxic to many organs, systems, and maybe a contributor to restless leg. There's a couple other physical symptoms that are substantially connected with restless leg syndrome. One is idiopathic pulmonary fibrosis, where for unknown reasons, lungs become scarred over and the scar tissue interferes with good oxygen exchange. And that we know is a risk factor for developing restless leg syndrome. End-stage kidney failure is also a common contributor or cause of restless leg syndrome. And interestingly, for people who are in end-stage renal failure, kidneys are failing, who get a kidney transplant, some of those people have their restless leg syndrome go away and some of them don't. So it's not just simply a generic marker of overall kidney function or how well your kidneys are doing. And it's not completely clear what's the mechanism for the connection between kidney failure and restless leg syndrome. There's also a connection, increased incidence in irritable bowel syndrome and restless leg syndrome. And as I've mentioned before, those with ADHD are more likely than the general population to have restless leg syndrome. One of the possible reasons the two are diagnosed together is that restless leg syndrome, particularly as it gets more severe, does cause significant sleep deprivation. And we know that sleep deprivation produces a syndrome that looks actually pretty much like ADHD. So attention is impaired, sustained concentration is impaired, emotional regulation is impaired, alertness is impaired. A whole host of executive functions seem to do worse when you are sleep deprived. So some of the overlap could be simply because in severe restless leg syndrome, there is a sleep deprivation that can look like ADHD. Now, however, the connection between restless leg syndrome and ADHD is there even in milder cases of restless leg syndrome, or even when there's no documentation of significant sleep deprivation. So that can't be all of the reason for the connection. And another possible connection between the two is when restless leg syndrome gets severe again, although classically it's presenting at nighttime and evening as someone's getting ready to sleep, but in many people the condition progresses and it ranges on in degree of severity. With severe restless leg syndrome, some people have symptoms throughout the day. Again, it's particularly when they're at rest, they have the need and urge to move their legs, and if they don't, they feel worse and worse. And particularly in children who can't articulate well why they may be so restless or hyperactive, it's thought that some kids with restless leg syndrome get misdiagnosed with having ADHD when it's really restless leg syndrome. So restless leg syndrome, we know, is a condition that is underdiagnosed. That doesn't mean there are some people who might be diagnosed with it who don't really have it. And the numbers on how commonly these co-occur, lots of reports or commentaries sort of repeat these old figures. So there's a survey done or a meta-analysis essentially done in 2005. So it's almost 2 decades old now. And its conclusion was up to 44% of those with ADHD have restless leg syndrome or significant symptoms of restless leg syndrome. Now, those numbers came from 5 different studies. Again, these are all pediatric cases. Of those 5 studies put together, there was only a total of 260 subjects who had both conditions. And some of the studies found somewhat lower rates than 44%. So you should take those numbers with a grain of salt. But again, it seems among those people with ADHD, they are having restless leg syndrome clearly more often than the general population does. And looking at it the other direction, of those people who have restless leg syndrome, that same meta-analysis found that up to 26%, so up to a quarter of those who have restless leg syndrome also have ADHD. But again, that number was drawn from just 3 different studies, and there were only about 230 affected subjects. Now, there have been some subsequent studies, not a lot, and most of them were also fairly small, some of them done in adults, and the numbers, again, are in those same general ballparks. But again, take those numbers with a grain of salt. Other features are that it's particularly hyperactive ADHD symptoms that seem to be linked with restless leg syndrome and less clear association between inattentive symptoms. And in at least some of those individuals who have both ADHD and restless leg syndrome, there are documented, again, how prevalent this is not clear, but at least some people who have both conditions do have documented iron deficiencies, and iron deficiencies probably in particular parts of the brain, particularly the striatum, the caudate, putamen, globus pallidus, deep in the center of the brain. One of the consequences of iron deficiency, so hemoglobin is the molecule that's in red blood cells that carries oxygen throughout the body. It's actually the iron molecule in hemoglobin that is responsible for binding to the oxygen and giving blood its oxygenated state, its red color, and its bluish, purplish color, and a deoxygenated state, or brown. So two different consequences of iron deficiencies in parts of the brain can be hypoxia, low oxygen levels, and actually demyelination. So the insulating sheath on neurons can be degraded, or on the axons, so that neurotransmission along pathways is less effective or efficient. And demyelination has been seen, at least some brains of individuals who had restless leg syndrome and some individuals with ADHD as well. So the consequences of hypoxia, if you shut off oxygen, one of the things that happens is there's a big boost in dopamine from the striatum, from that globus pallidus, caudate putamen center of the brain. So increased release of dopamine. Most of the studies on this have looked at acute traumatic events in rodents, but there's some evidence of hypoxic events during delivery. So if the baby is not getting enough oxygen as it is being delivered, as birth is happening, that hypoxic injury, low oxygen injury, is associated with a surge in dopamine release, particularly in the mesocortical limbic system. So from that central striatal region, those are the projections relating out to the prefrontal cortex, to the emotional cortex, hippocampus, amygdala system. So most of these studies are looking at acute events, but there's some evidence also that chronic low-grade hypoxia, which could be associated with anemic states, low iron states. Hypoxia would be associated with ongoing elevation of striatal dopamine release. And we know that one of the consequences, and this has been measured in people with restless leg syndrome, is that there is consequent downregulation of the dopamine 2 autoreceptors. Those are the receptors on the nerves themselves that are releasing dopamine and help regulate dopamine levels. So I'm talking about a surge or an overabundance of dopamine, and yet most of the drugs we use to treat restless leg syndrome are actually drugs that are boosting dopamine signals. So here we get into the circadian rhythm factor and biological rhythms. So the thought is that the dopamine system, or dopamine in the mesocortical systems, is being released at too high a rate or too much. And there's some corresponding downgrading of receptors, particularly dopamine 2 receptors in the striatum and in the peripheral, and the body itself have been looked at. Superimposed on these overall levels, there is still a prominent daily rhythm. And the prominent daily rhythm is most of the dopamine you get is being released early in the morning during the day, and much lower levels later on in the day. So the thought is that in this chronic overactivation of the dopamine system scenario, at the beginning of the day, the system's pretty well matched. The receptors are able to cope with this surge of dopamine. So when less dopamine is being released, and you have maybe upregulation of dopamine through your receptors, or at least they're sitting there waiting for it, and they are getting too little dopamine. So most of the major drugs that have been approved for treating, and do seem to successfully, at least in the short term, treat restless leg syndrome, are what are called dopamine 3 agonists. So they are binding to the dopamine type 3 receptor. That's the postsynaptic, particularly in prefrontal cortex, where we think lots of what's going on with ADD and restless leg syndrome is occurring. These drugs are again making up for that mismatch at the end of the day that isn't demonstrated at the beginning of the day. So that the very first drug that was found to be effective for restless leg syndrome back in 1982 was L-Dopa. L-Dopa is just the precursor of dopamine. So to give someone enough L-Dopa in both the brain and the body, you get more dopamine being produced. Often it's actually administered with a carbidopa, which is called a decarbylase inhibitor, which basically only is in the body, doesn't get into the brain. That prevents L-Dopa from being converted to dopamine in the body. So more of the L-Dopa gets into the brain and can be converted into dopamine in the brain. Anyway, studies in Parkinson patients who had restless leg syndrome in 1982 showed that L-Dopa, which is used for treating Parkinson's, the dopamine deficit in Parkinson's disease, was again also effective for treating restless leg syndrome, which again we think fundamentally may be coming from an overabundance of dopamine at the wrong time of day. They never pursued an indication for restless leg syndrome, but about 20 years ago, Pramipexole, which is Mirapex, and Ropinirole, which is Requip, those are both fairly specific dopamine 3 agonist agents. They were approved for treating restless leg syndrome. They're both generic drugs and cost about $10 a month. And both of those can be used as well for treating Parkinson's disease, but they're usually used in much larger doses for Parkinson's and seem to be effective in restless leg syndrome. There's a third dopamine type 3 agonist called Rotigotine, also brand name only, called Neupro. That is a patch, so it's a more steady, prolonged release. Some people think that's a better fit, and I'm going to get to why in a second. Rotigotine is actually hits a lot of different dopamine receptors. Its strongest effects do seem to be on the dopamine 3, but it is also acting on dopamine 1, 2, 4, and 5. And since it's a brand name, and probably because of the mechanism of delivery is through a skin patch where it's absorbed steadily, it costs more than $1,000 a month. The fourth medicine in the US that's been actually FDA approved for treating restless leg syndrome is Gabapentin, which is thought to be primarily a GABA analog, and it's focusing that there are clearly other neurotransmitter systems that interact with our dopamine systems. Experts and neuroscientists have pointed out that if you are treating what is essentially a surplus of dopamine with a dopamine type 3 agonist, you're actually perpetuating the problem, even if you're getting by with just little doses, particularly targeting the end of the day. Clinically, what we also observe is that people who are on these medications often have a worsening of symptoms. They miss a dose or have to stop their drugs abruptly, and that many people also develop tolerance to these drugs. So we're just sort of amping up the system, more dopamine there, more downregulation of D2, more mismatch at the end of the day. Although at the dosages that are currently used to treat restless leg syndrome, some people have dizziness, some people have nausea, some people have mild side effects. So usually pretty innocuous in terms of immediate short-term physical side effects. But one of the downsides, and I've seen cases of these without having lots of people or seeing lots of people who are on dopamine 3 agonists for their restless leg syndrome. So impulsive compulsive spectrum disorder. So compulsive gambling. I had worked with a woman who was in her late 50s, a very sober, restrained laboratory technician who developed a gambling problem, actually gambled away all of her life savings, didn't have money left to pay for rent. She pretty much destroyed her life. And it was after the onset of taking the restless leg syndrome medication, she went through gambling treatment. She felt her restless legs was so disruptive to sleep and her living that she would not give up those medications. So I worked with a guy in his late 70s who he had Parkinson's disease and restless leg syndrome, developed an addiction. He was paying prostitutes, and in the old days when there wasn't as much online and you had to go to the video store, spending inordinate amounts on videos or sexual urges, which he had not had a problem with that in the previous decades of his life. Overeating can be another impulsive compulsive spectrum problem that happens from D3 agonists, and what's called punding, and that is assembling and taking apart, putting together, or sorting things and collecting, doing mechanical tasks that have no specific purpose or goal. It's just sort of motor movements repeated over and over. It's more complex and task-oriented than just fidgeting, but it's not doing this to achieve a goal or to fix a clock or repair your car or something like that. So in addition to the dopamine-3 agents, clearly if iron deficiencies are implicated in a thorough panel of iron, or you need to do more than just check iron levels, because iron's tightly bound to ferritin, a protein that carries it around in the blood, and regulation of iron levels is moderately complex. But there are certainly some cases of restless leg syndrome which have been resolved or responded to iron supplementation. And currently there's evidence that a host of medications, most of which initially were anti-seizure medications, and are affecting glutamate, Gabapentin, other systems. So Tegretol, which is Carbamazepine, Lamotrigine, Lamictal, Topamax or Topiramate, Klonopin, the benzodiazepine. All of these have some evidence of being helpful for treating restless leg syndrome. So we also know some things that make restless leg syndrome worse. So drugs that are dopamine blockers, and the big group of drugs at the top of the list there are the antipsychotic medications, consistently make restless leg syndrome worse. And there's also evidence that for many people, serotonergic drugs, including serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, tricyclic antidepressants, and maybe mirtazapine in some reports is the most likely of our antidepressants to trigger or worsen restless leg syndrome. And at least for many individuals, caffeine, nicotine, alcohol can exacerbate it, as can diphenhydramine or Benadryl. How many of these are due to direct effects on the dopamine system is unknown. So one of the things that's surprising is that there are, at least that I could find, there's only a handful of case reports of using dopamine agonists for people who have both restless leg and ADHD to see if that is sufficient or can help with ADHD itself. So there are a tiny number of reports that drugs like Ropinirole and Pramipexole can help with ADHD. And there's even less that I found studied on whether the stimulants, the mainstay treatments for ADHD, whether or not those are helpful, presumably at very tiny doses. So unfortunately, there's, as many of the topics I talked on, less hard data than we would want. That's about all I'm going to say. I will look to see if there's any questions. Is bupropion as effective as atomoxetine in treatment of ADHD? I mean, we have lots of studies that compare, bupropion or atomoxetine or methylphenidate compared to a placebo group, where clearly all these drugs work better than the placebo for ADHD. One of the problems with placebo for ADHD is that most of these drugs have a subject, you can feel them, and if you don't feel activated or euphoric or more alert or more active, then it's pretty easy for people to know they're being treated with the placebo. So there may be differentiation from the placebo just because people know that they're taking the active drug. Numerous times people have tried to do meta-analyses looking at studies of how well atomoxetine Strattera works, how well bupropion works, how well Cymbalta works, how well Qelbree works. And they combine studies that are looking at different populations, they're looking at different dosages, they're looking at different criteria for assessing how well they work, and then sort of comparing, are these effect sizes similar? So again, my looking at those meta-analyses or combining different studies together, they show Adderall being at the top, and they show this cluster of things which seem roughly equivalent. Again, Strattera, atomoxetine, bupropion, probably duloxetine, probably Qelbree are in this group. And when we say better, it's the percentage of people with ADHD who are helped and the extent that symptoms are reduced. at a group level. My big point is that most of those studies showed that Ritalin methylphenidate is actually at this lower group of other agents, not working nearly as well as Adderall, but actually not significantly surpassing these other groups, even though traditionally we are lumping methylphenidate with those others. So I'd say at the level we can look, bupropion appears about as effective. Again, these are group numbers. So there are clearly individuals who get a good response to bupropion who don't get anything from Strattera. There's certainly people in the other group. I would say in my hands and many of my colleagues, bupropion tends to be much more predictable in terms of side effect profile and therefore easier to dose. And crucially important is that many people can start at a dosage which is already effective for ADHD symptoms, which appears astonishingly uncommon with atomoxetine. Stay healthy, stay happy, and thanks for tuning in, and share this channel with other people if you felt it was beneficial to you.